Starting your 2 minutes time.
Okay, ma'am.
Hello, are you there?
Yes, ma'am.
Yeah,
Should I
read
start
that.
now?
No, just read the. It's okay. So you have read it because I have not shown you the task.
Okay. Next page.
No, this is last page, first and second. Started your 10 minutes time. Start.
Hello, I'm Tanya. I have gone through the case scenario and ready for the discussion.
Okay. So, Dr. Tania, how you would like to conduct a pre-operative round on this case in the ward a day prior?
First of all, during the pre-operative ward round, I will introduce myself. This is a case for opted for diagnostic laparotomy for chronic abdominal pain, and she was trying for having a pregnancy for last 2 years. So for this patient, I would like to review her history, like the duration of the pain, and for the treatment she has taken at her and also I would like to know the previous investigation and treatments. So I would like to go through her notes after taking her consent. Also, I would like to know the last menstrual period and contraception history to exclude the pregnancy. If needed, I would like to do urinary pregnancy test to rule out, and any previous pregnancy or previous surgery or any significant medical history and allergy to any medications. I would like to know. And also, I would ask the patient whether she is discussed regarding the alternatives with provided patient information leaflets. And preoperatively, I will assess her risks according to her history, and also anesthetist will check her preoperative assessment. And I will also check her consent and ensure that proper counseling was done and patient is understand the possible the diagnostic laparoscopy and also if needed any possible treatment. And also, enhanced recovery program will be followed for this patient. Bowel preparation and prophylactic antibiotic can be given if needed, and also also and then encourage the patient to ask anything if she have any query.
Okay. So now, since you are under performing this procedure, once the patient has been induced, how you are going to proceed further? Take me through the steps
Okay.
of the procedure.
The patient was under anesthesia. So, first of all, follow the WHO safe surgical checklist. That means introduction of the members of the team, and also confirm the procedure being performed, and for surgical precaution to be taken, and and also check the equipments, and ensure that the equipments and ergonomics are ready, and it is ready. And then I will do position of the patient, lithotomy position, then clean the vagina, and also ensure that bladder is empty. I will perform the vaginal examination, and then to check the size, mobility of the uterus, and insert the uterine manipulator, and then aseptically clean the abdomen, and also ensure proper draping. After that, in the table, before inserting the brace needle, patient will be in the table in a flat position. I have to ensure that. And here, if there is any concerning, like any previous history of PID, in that cases we can involve our seniors or well-trained surgical staffs if any difficulty is suspected. Then use here we will ensure that the carbon monoxide tubing is connected to the inflator, and also light source to the stack system. Then check the gas flow and pressure is normal. And before inserting the varus needle, I would like to check the varus needle patency, and patency of the varus needle. And the patient will be supine position on the OT table, and then abdomen is palpable for whether any mass is or for any mass. And in case of lean and thin patient, also we have to locate the great vessels like aorta, and just to avoid any intra-abdominal injury of the great vessels or any organs. And here, if the patient have any previous scar, we have to avoid this area for choosing the entry point. Usually, we for face needle insertion, we insert the face needle by giving the vertical skin incision in the lower border of the umbilicus to avoid the unnecessary pressure pass through the trocar through the skin, and also avoid going too much deep to the peritoneal cavity. So once the varus needle inside the peritoneal cavity, there will be two click sound because it will penetrate to fascia. And after that, we will check whether the varus needle inside. And one thing I would like to mention, that the varus needle will be inserted vertically, I mean right angle to the skin. And after whether it is enter into the peritoneal cavity, we can test it by double click test, or hanging top test, and aspiration test. And here, the pressure of primary trocar entry is 20 to 25 millimeter of mercury. And after that, once it is inside the cavity, the pressure will be reduced to 12 to 15 millimeter of mercury. Then we will do will do the secondary to trocar entry under direct visualization. But here, if there is the failed attempt of varus needle insertion, then we need to inform the consultant, and also other techniques should be adopted, like open hasten technique or Palmer's point technique should be used in that cases. And here, once the base needle inside the cavity, it will be moved 360-degree underneath the skin to see whether any adhesion present or not. Then under direct vision, we will insert the secondary talker, and we you have to make sure that there is no puncture of the inferior epigastric artery. So with precaution, we have to give entry of the secondary talker,
Okay.
and that
Yeah,
yes.
that's it. So, what in her history will you make additional steps to minimize visceral injury? What are how you will be minimizing visceral injury and how you will be minimizing bowel injury?
Okay, for minimizing the visceral injury, we have to take the history, whether any previous history of pelvic inflammatory disease or previous history of any surgery, like previous history of cesarean section or laparotomy, or any inflammatory disease like Crohn's disease, and also if a patient has the low body mass index. And regarding the bowel injury, for we can overcome this, if the I mean if there is suspected risk of bowel injury, we can involve the senior surgeon or experienced surgical staff, and here entry through the Palmer's point or open Hessen technique, and and make sure that if any injury is available, then involvement of the specialist bowel colorectal surgeon is there.
Okay. How and what about visceral?
Visceral injury also in case of like body mass in the low body mass index, there is a, we need to adopt the technique of Palmer point technique or open Hessen technique, and here also involvement of the senior surgeon, and also take precaution in case
Within one sec,
from
when
the
your
history.
time is finished, now your time is finished. Within 1 minute, just tell me what will be your post-operative care in this patient.
So post-operatively, the patient complete the post-operative notes and also discuss the agreed plan for discharge, and also write down to the GP regarding her further plan of management. And patient will be prescribed with adequate and pain relief, and also enhanced recovery program will be adopted for this patient. And according to findings of the diagnostic laparoscopy, her further management plan will be discussed to another appointment. So she will be given to that appointment for that. And if any complication arise, then we need to inform, debrief to the patient and document everything. And as a duty of control, um, explain to the patient regarding this after the report, after doing the incident reporting.
Okay. Okay.
Thank you for your time.
Yeah. Anybody would like to give a feedback? Just wait.
Uh, Ma'am, can I do the feedback? I'm Fatiha. So can I do the feedback, please?
Yes, you can give.
Yeah. So Tanya did a very good presentation. I must appreciate that. She talked about the like before she went for this procedure. And one thing, like in the when she was talking about the pre-op, we can add the BMI. BMI is very important. And also, if we can say that the patient is aware that if the diagnostic laparoscopy might not be able to find out any cause in 50% of cases, that the patient is well aware about. And apart from that, during the entry also, it is important, like she mentioned, I appreciate that the 2 clicks are heard, and the Palmer's test and hanging drop. But the best test is when we enter the abdomen, the pressure should be less than 8 millimeters of mercury. That if we add that, I think it will be better. And During the secondary trocar, like how do we recognize that we are not entering the inferior epigastric? That also is important, that we focus the camera and under the vision of the first camera, and we go lateral to the median umbilical ligament, so that we do lateral to it, so that we prevent injuring it. This is fine. And yes, depending on the BMI, if the BMI is high, we can initiate from the Palmer's technique or by the open Hassan. And low BMI also, because only 2.5 centimeters is the iota. Then also we can initiate from the Palmer and the open Hassan rather than going into the umbilical port. That is what I want to add, ma'am. Thank you very much.
Yeah, very well said. May I know your name?
Fakiha.
Pathia, yeah, very well presented. A few more important points what I wanted to tell you regarding Tanya. Tanya, you were individualizing your sentences. If you are going to individualize your sentences, you are not going to get time adequate to complete this task. This task, you have to finish it off within that stipulated 10 minutes. So your first question was almost 4 minutes. Your next question was almost five minutes. So last 1 minute I had, and that's the reason I had to club two questions similar at a time.
Okay.
Okay, so when
Yeah.
you know that there are total 5 questions, you have to have that idea. Okay, I have to manage the time very precisely. You were saying all the points, but then for each point you were using individual sentence. Got it? So if you are
Yeah, yeah.
saying,
Very fast. I
yeah,
have that.
yeah,
Yeah.
yeah, and you are repeating few things again and again. So no, you do not need to repeat it out. So if you wanted to ask me, Miss, whatever Dr. Fakia has given a feedback, nicely she had given a feedback. So if you wanted me to describe the steps of the laparoscopy, it should be fixed in my mind. Okay, so you know that under all aseptic precaution, WHO safety checklist will be done, activity risk assessment will be done, patient in lithotomy, dorsal lithotomy position, Lloyd Davis position, unpainted, draped under all aseptic precautions, bladder catheterized. Would like to go for an examination under anesthesia to see, confirm my preoperative findings, any abdominal masses or any scars, so that I will change my approach. Then I have been asked to perform a procedure. So I will be going through with a various techniques. So yes, I will ensure that all equipments will be checked and connected. Second, hold your Veris needle. Before that, check the patterns of the Veris needle. Hold it in a pen-like fashion. Yes, the patient should be horizontal. It should not be head low or head high. Choose base of the umbilicus as a incision point, because the thinnest portion, more cosmetic, less blood vessel. You have to go at 90 degree, 2 clicks. 2 clicks, first will be rectus sheath, second will be peritoneum. No inadvertent movement. No inadvertent movement. Once it has been entered into the peritoneal cavity, confirmed with the help of either aspiration, insertion of fluid, and pressure changes. Okay, so this 3 way you can check whether you are in a intraperitoneal cavity or not. And once this has been complete, ensure that the pneumoperitoneum will be created adequately, which will keep your bowel abdominal contents away from your entry site. And once pneumoperitoneum has been created, remove the Veris needle, extend your incision, and introduce trocar and cannula. Once the trocar cannula has been introduced, remove your trocar, introduce your laparoscope, and visualize completely to see whether there are any inadvertent injury marks seen. Okay, so this way you have to say the lines. If you are going to say, I am going to do this, then you are going to say again the next sentence with these sentences. The time will not be on your side. You know, you are having adequate knowledge to pass this task. Now, our major concern is working on a time management. A critical feedback, what I am giving it to you, apart from Dr. Fakia, who has given you the very nice feedback. Okay, so
Okay, ma'am.
yes, yeah. So you introduce yourself. SBAR tool is very important situation, that is Mrs. What I had just mentioned, ABC. Sometimes there might be a patient's name. This is a very common RCOG Viva also. almost on this similar format, there is a RCOG for task also. She is posted for diagnostic laparoscopy in view of chronic pelvic pain, and also she is anxious to conceive. So she needs assessment and further recommendation. So I would like to introduce herself. Would like to check her symptoms. Okay, onset, duration, progression, LMP, UPT. Yes, you mentioned severity. Ascertain whether there are any new symptoms or whether that symptom has been disappeared. It is very important thing if whenever you are going to put it, because most of the time they had seen this patient 3 months, 4 months back. So whether there are any new symptoms or what about her, any new symptom she had presented, or the symptom has been subsided. Okay, and patient is still happy to go ahead with the procedure. So risk assessment, so you mentioned medical, surgical, BMI and smear. This is all about risk assessment. Okay, so medical comorbidities, you need to optimize the medical comorbidities, BMI, smoking. These are the comorbidities, so these are the risk assessment, and JOA witness. Okay, so all these needs to be optimized. That is, I will categorize all these into one thing, that is risk assessment for that person for while performing the procedure, and second is surgical history, because then it will allow me to change my approach. Okay, you have to justify why you want to know these all these things. Then pre-procedure. Okay, so since the CPP means, that means chronic pelvic pain, the presentation is chronic pelvic pain, so anticipated adhesions are expected in this case. BMI is very important. A high BMI or very low BMI is prone to cause a difficult entry or injury to the blood vessels. In a low BMI, injury to the blood vessels. Okay. Consent. I will also ensure that the patient has signed the consent. The patient has been explained regarding the risk and benefits, and alternatives has been discussed with the patient. Pre-anesthesia review will be done for this case, and if possible, if the patient is having any comorbidities, then the optimization of health with the help of enhanced recovery pathway has been completed. And at the end, I will just ask patient and encourage her to ask questions if she is having any questions in her mind. Okay. So now she is in theater. Yes, you had maximum points you had mentioned. I don't think there are only, means you mentioned most of the points. Okay. And they were very good points. Okay. But only thing you have to say in a chunks. Small sentences will kill your time. Okay. So WHO safety checklist, lithotomy or Lloyd Davis. Okay. So here actually they had mentioned lithotomy, but I will say that Lloyd Davis flat. She will be flat on she will not be head low or head high. She will be flat on the table. Under all aseptic precaution, performed by manual pelvic examination and then insert uterine manipulator. Okay. So insert uterine manipulator, clean the abdomen and apply drapes. Bladder has been catheterized. I had not mentioned here. Okay. Okay. So the first thing here, actually, the bladder needs to be catheterized. Okay. Safe use of electrocautery, safe senior involvement. It is very, very important. So you should be aware about all the principles regarding the safety of electrosurgery, and your consultant should be around. Any difficulties, if you are anticipating, the consultant should be available. Okay, you mentioned both the points. Check spring action of for the patency. Varus needle pen holding perpendicular, that is 90-degree. Infraumbilical region, that is at the base of the umbilicus. Why so? Less less blood vessels. Peritoneum is very tightly attached, and cosmosis. Stabilize the abdomen. This is one of the important point, because you cannot straight away go. So you have to hold the abdomen with other hand and elevate the abdomen. That is stabilization of abdomen, and insert the Varus needle at a 90-degree with double clicks. First and second, no inadvertent movement. So this is very, very important point. Whenever the confirmation of Varus needle is into intraperitoneum or is intraperitoneumly, you have to check with the help of either pressure changes, Palmer test, or aspiration. No inadvertent method to see whether it is a freely mobile or not. If at all it's in bowel or in any organ, then you are going to extend the injury. Okay, extend the injury. So that is one of the very important patient safety point. Create pneumoperitoneum. The Konje has mentioned 3 liter, but 2 liter, about 2 liter you can mention, or optimum pneumoperitoneum can be achieved. It's okay if you will not give them the exact figure. Once it has been checked, remove the varus needle, extend the incision, introduce trocar and cannula, remove the trocar and introduce your scope. Check with the laparoscope, 360-degree under port site, because bowel is the most common organ to get injured at the site of varus needle. Okay, once the procedure has been performed, then you are going to remove it. So this much only I wanted to ask how you are going to perform the procedure. I don't want it. I am not I was not keen to ask that question to you. Okay. What in her history make you take additional steps to minimize visceral injury? Yes. First is, what are the visceral injuries where you are expecting a visceral injury? Basically, low BMI. Those patients who are having a low BMI, they are at risk of injury to aorta or even external iliac vessels, external or internal iliac vessels. Okay, because the distance between the skin and the aorta is very less. Any previous surgery, previous infection, any abdominal surgeries, or any inflammatory bowel disease, this also puts them at risk of bowel injury. Okay, so these are putting them at risk of bowel injury. So faulty technique is another. Okay, inexperienced person, faulty technique, these are the alternatives where person can cause visceral injury. So open Hassan or Palmer point technique is an alternative to minimize the visceral injury here. The next point, bowel injury. Okay, so how you are going to overcome? So the first is, when anticipation of bowel injury, when can the bowel injury happen? When can? Okay, so whenever there will be previous surgery, any previous surgery, so incidences of bowel periumbilical adhesions are 0.068% if the woman is not having any surgery, 1.6 if it is laparoscopy, 19.8 if it is transverse, 52% if it is previous midline laparotomy. So these are the figures from this STOG article. Okay, so if at all you do not know the figures, but you at least know that, okay, the chances of having periumbilical adhesions are very high once the incision will be vertical. History of endometriosis, STI, IBD, all those are putting these patients at risk of intra-abdominal adhesions. And in those cases, you can anticipate that there might be bowel adhesions and you may have to change to your entry point. So Palmer point is the safest point. Open Hassan is another technique where you can go safely. Make sure your seniors will be available to assist the procedure. And if at all you have caused any injury, early identification and prompt action will save the complications post surgery. Okay, so this is another point. The last point is very important, which is the post-operative course. So complete the operative notes, debrief about course, post-surgery, suggest option for management, document it in her care plan. The GP surgery will be involved regarding that. 24-hour contact details, follow-up plan will be made for this patient. Adequate pain relief, ensure bowel bladder opened up, and discuss discharge once the patient will be stable. Discharge home with an appropriate appointment to see in the outpatient may just wait. May start treatment if she's happy to do so. Okay, so whatever treatment plan we have given it to her, so she can start with her treatment plan. Okay, so a good attempt, Dr. Tania, just combine the sentences. Okay, just combine the sentences so that approach will be appropriate. Now,
Okay, thank you, ma'am.
yeah. So coming to the domain-wise scoring, able to confirm the symptoms that has led to the planned procedure. Risk factor you had mentioned. Review investigation results, initiate appropriate investigation. Especially here, LMP and UPT is very important. One of the very important patient safety point whenever it is core surgical or post-operative module. Okay, pregnancy test has been done. Okay, and consent has been signed. Communication with patient, introducing in structure discussion. Whenever you want to communicate with the patient, 2-3 things you just need to say. Whenever whatever you are going to discuss, you are going to introduce yourself to the patient. The consent has been signed, alternatives has been discussed, pros and cons of that particular procedure has been explained to the patient. So this is a consent is a communication. It's a written communication between you, a doctor, and a patient. And ultimately, debriefing. At the last, debriefing and offering patient a patient information leaflet. Okay, so this way the communication in patient domain will be marked in structure discussion. Okay, communication with colleague. So when you have to call your colleague, involvement of senior, uh, pre-anesthesis checkup, so your involvement of anesthetist, feedback to GP after the procedure. Okay, and when to call upon senior and when to take call for help is very important. So that is communication with the patient. Patient safety, WHO safety checklist, all the safety steps throughout the laparoscopy. Okay, one step here and there, you are not safe. So, as such, the safety was not an issue with you. You know how safely you have to introduce your various needle and how safely you have to perform your laparoscopy. So, safety is not an issue. Safe prescription after establishing drug allergy, ensure positioning of the patient, including checking at every stage the safety of equipment and procedure. You had checked it. Meticulous assessment of bowel during entry, 9 quadrants. They had mentioned 9 quadrant, but here I just wanted to ask you how you are going to perform the procedure. Okay, introduce various needle. And the knowledge. The knowledge is about chronic pelvic pain. The knowledge is about diagnostic laparoscopy and the RCOG Green Top guideline regarding safe entry in laparoscopy and visceral injuries at laparoscopy. Okay, so all those things is important. Knowledge is okay. Patient safety is okay. Communication with colleague is also okay. Miss, I'm clearly passing you in this task, but the only concern is the way of presentation, the approach you need to change, Dr. Tahani. Okay.
Okay.
Anybody's having any question? Okay. So now